Hey everyone, welcome to RT Review. We're going to talk about keywords today, terms that should help you identify what type of care plan that you should start building, and that should point you towards certain clinical pictures that should be coming to mind when you see these words. This is very important in helping you on the TMC and the CSE, and then later on during your career. So the first one we're going to talk about is in association with COPD. You may see the words lethargic, sleepy, somnolent. You know that those occur when the patient has been given too high an FiO2. So your care plan should begin with lowering that oxygen delivery device down to maybe 2-liter nasal cannula or a 28% Venturi mask. But the very minimum amount of oxygen that still holds that PO2 around 60 and that saturation around 90, 92 is plenty for them. Okay, so lethargic, sleepy, somnolent all point toward lowering the FiO2 and to a healthy level for a COPD patient. Another keyword that should help you in evaluating whether you need to initiate a COPD care plan is digital clubbing. We know that digital clubbing occurs in patients with chronic obstructive pulmonary disease because the chronic hypoxemia has resulted in the body's reaction of creating more red blood cells. So when you check their hemoglobin, they may have a hemoglobin of 19, and we know that a normal hemoglobin is around 12 to 14. But the body has amazing ways of trying to correct problems to keep everything balanced and in homeostasis. So a way that the body responds to chronic hypoxemia is creating more red blood cells. So if that happens, then that makes the blood thicker, and it causes polycythemia, or many red blood cells. And that causes thickening in the digits of the fingers, and they become wider to appearance. And we've looked at several pictures online about that show digital clubbing, and you'll definitely see this. And a lot of times their nails are yellow because they've been chronic smokers, and it's caused their tips of their fingernails to even change colors, and the tips of their fingers may also be affected. So look for that sign in your patients when evaluating them, and know that you need to make sure that you're using an FiO2 of only 2 liters or 28% with the Venti mask on these patients. That way you don't send them into respiratory failure due to a high FiO2. So we know if we see a patient with digital clubbing, or that is lethargic, sleepy, or somnolent, we need to make sure that we guard that FiO2 that's being delivered. Another sign of COPD is the use of the words increased AP diameter. We know that COPD results in an increased RV, residual volume, because of the air trapping, because the patient is unable to exhale all of the air they should be able to, and so that causes an increased AP diameter as it's caught inside and remains in the lung. So our residual volume and our TLC, total lung capacity, is increased in our COPD patients. So if we see the words increased AP diameter, that goes along with digital clubbing and a lethargic, sleepy, somnolent patient that may be headed into trouble and may need a care plan to keep them off the ventilator and headed the other direction from respiratory failure. Muscular hypertrophy, that's another key word that should key us to begin a COPD care plan. The best way to do that is to go ahead and treat the symptoms, get them out of the impending issue, whether it be respiratory failure or a serious exacerbation. But anytime you see muscular hypertrophy, think of accessory muscle use and chronic shortness of breath and chronic increased work of breathing that comes along with COPD. So if you see muscular hypertrophy, think asthma, emphysema, cystic fibrosis, bronchiectasis, chronic bronchitis, those diseases that are included under the umbrella of COPD, and how that those muscles have built up over time because of excess use due to shortness of breath. So another thing that we see a lot with COPD and chronic cardiac diseases is cardiomegaly, that chronic hypoxemia over time will cause that heart muscle to have to work harder, just like the accessory muscles, and that muscle will enlarge. So cardiomegaly is a term that means enlarged cardiac muscle, and that's due to chronic hypoxemia and the effort of the body. The body is truly amazing. It has different ways for compensating for problems. If one thing doesn't work to help it maintain a homeostasis, it's intelligent, and it knows to do other things. Like if there's not enough oxygen available on the hemoglobin, it will create more red blood cells in response. So be sure to look for these key signs. So we want to look at the chest x-ray of a COPD patient, and the key terms that are associated with a chest x-ray on a COPD patient would be flattened diaphragms, because that chronic air trapping has resulted in flattened diaphragms because the lungs have been hyper expanded over a chronic amount of time. So it's pushed the diaphragm down. The intercostal spaces may be expanded due to chronic air trapping because of COPD. So that would again cause our increased AP diameter or barrel chesting. So some other signs and symptoms of COPD when you go in to evaluate the patient, they may be leaning forward on their bedside table because they're trying to elongate those lungs and make it easier to breathe and more comfortable. They look for any way of doing that. They also may be creating like a pursed lip, like playing the flute, because they're trying to create their own increased expiratory time to relieve that trapping of the air and to try to decrease their own RV. So an increased TLC, total lung capacity, due to increased residual volume, due to air trapping in the lungs is something that we see. And that's going to cause the increased AP diameter, and it's going to cause an elongated lungs and flattened diaphragms in the chest x-ray. We may also see mucus if they have chronic bronchitis or cystic fibrosis, so one of the mucus-producing conditions included in COPD. We may see mucus, and that would appear as white on the chest x-ray. Of course, anything solid like alveoli that are filled with mucus would be white. So look for that on the x-ray. Decreased vascular markings may also be seen on the chest x-ray of a COPD patient. So we want to be able to evaluate quickly when we're doing the questions on the exams, and also in the emergency room and working with these chronic patients. So we know that if we do have spirometry results available, that our FEV1 is going to be reduced in a COPD patient. The amount of air they can exhale in 1 second is going to be reduced. And then we know that our FEF 2575 is going to be reduced, because that's a reflection of the small airway obstruction. And then the FEF 200, 1200 may be reduced, which is a reflection of the larger airway obstruction. And then our peak flow, or PEFR, may be reduced on our spirometer, which is the amount of air the patient can breathe out quickly in the first 0.8 of a second. So that's also information we need to look for to identify that the patient has COPD. Okay, so we need to make sure our COPDers stay hydrated. We need to make sure they have an acceptable PO2 and SPO2 to keep everything balanced without throwing off the pH and without increasing the PCO2. So be careful with those FiO2s on your COPD patients. We need to make sure that we're doing nocturnal oximetry to see if they need oxygen at night, that we're doing our spot checks during the day on room air to make sure that they have oxygen for home use once they're discharged if they need it. So anything less than 88% that you on room air would qualify the patient for home oxygen, and then on a spot check, and then anything during a nocturnal study that is less than 88% for 5 minutes or more would qualify the patient for home oxygen at night. Remember that they need to have that bronchodilator for daily use, the long-acting bronchodilator like Atrovent. They need to have a short-acting bronchodilator like albuterol on hand for when they're having an increase in bronchospasm, shortness of breath, and wheezing. But they need to be also on a preventive medication like Spiriva or Advair, a corticosteroid, to keep down the inflammation. So they need to make sure that they have a diet that the primary intake is of proteins as opposed to carbohydrates. We know that carbohydrates make all of us sleepy. If we have a lot of bread or a lot of pasta for lunch, then you can bet we're going to get sleepy. So imagine the COPD patient, that if that occurs and that causes increase in the PCO2, then it can be very detrimental to their quality of life each and every day if they don't follow the best diet. And that best diet is higher protein, higher fats, and less carbohydrates, and maintaining their hydration. So I hope these keywords have been helpful to you in identifying COPD patients, and then some of the care plan for dealing with COPD on a daily basis to try to keep them home out of the hospital with their families and reduce the amount of medical bills that they have financially. So it can be devastating to have a chronic disease. So, all right, well, thanks for listening. Make sure you subscribe below if you haven't. Follow so you get notices for when we send out new videos. So have a wonderful day.